At the height of the COVID pandemic, it was hard to escape stories about the virus. COVID was constantly in the news, podcasts, in our conversations. And while the whole world talked about COVID, the eyewitnesses to the worst of COVID, the frontline medical workers, often went unheard. These are the stories of the people who worked in hospitals, clinics, and emergency rooms day in and day out as the pandemic unfolded. This is what it was really like on the ground, as told by the people who lived it. Because if we don't tell our stories, someone else will. This is the Frontline Worker Project.
Welcome. So we are going to start with the basics. I want you to tell me what your job role is, where you work during the pandemic, and then what kind of job you do now, like where you work now. Also the city that you're in.
My name's Katie Douville. I'm 36 years old. I work through Rochester Regional Health. I worked there through the pandemic, on and off. I traveled for a little while. A lot of people did, but I worked at Rochester Regional Health through Unity Hospital at the start of the pandemic as a new nurse. And now I work in the intensive care department at a different hospital through the same network.
So we were talking a little before this started because we were talking about how probably talking to newer nurses who graduated, got off orientation, started orientation around the time the pandemic started, that we're probably going to get a variety of experiences depending on kind of the level of support they had at the hospital or whatever setting they were working in, So tell me a little bit about what it was like to be a new nurse orienting during the pandemic.
I graduated in the summer of 2019, which was before all that. We hadn't even heard the word COVID. I remember being in nursing school and we got fitted for N95 masks. And I remember my teacher saying, "You'll only ever use this rarely. This is just something that we use if our patients are rule out for TB. We never see stuff like this anymore." And then lo and behold, so I started at the emergency department nurse residency was where I was accepted to as a nurse graduate. I started there in August of 2019, and their residency program was top notch. I got such a well-grounded feel for being a nurse in general before I ever got into the emergency department. I worked upstairs for 3 months, I think, prior to coming down to work on the boarding patients in the ER. First, we were looking at lower acuity patients upstairs who had been admitted in our observations units. They were, walkie-talkies, simple things. They're there for like abdominal pain. They needed fluids. They needed Tums, a little Tylenol every once in a while, nothing crazy. They moved us to our cardiac telemetry unit where we learned about how to read strips and different medications, metoprolol, diltiazem, the onsets, the rates, and how fast you push things. And then we went to respiratory care where we learned about patients with trachs and things like that before we ever made it to the emergency department to work on those boarding patients who were admitted but didn't have rooms in the hospital yet due to hospital census. So I was probably a nurse for about 6 months before I ever laid my hands on an emergency department patient. And during that time, I still had my mama duck nurse for another 3 months, I think, before I was able to work on my own independently on emergency department patients. So it was a really, really solid introduction to nursing and emergency department nursing. So I felt like they really set me up for success, regardless of the pandemic. They really formed me into a solid nurse.
Yeah, so you were sharing one particular experience that was somewhat memorable for you on orientation regarding a patient who was having some breathing issues. Is that correct?
Yeah, I had gone to lunch, a rarity sometimes in the emergency department. But I was still early days coming off of orientation on borders, going into my time as an emergency department nurse, trainee, orientee. So I was starting to feel more comfortable. I had, I don't know, I don't remember how many patients I had at the time. It's been like 5 years now. But I had a good handful of patients that were just mine. I think like 4 or 5. And I had done their head to toes. I had assessed them. I listened to their lungs. I'd done, charted everything, and I'd gone to lunch. And you were watching my patients for me, had offered so that I could go to lunch that day. And I knew that my patients were in good hands. And I came back and you told me, Katie, one of your patients has a respiratory rate in the 30s. All morning has had a respiratory rate in the 30s, but you haven't done anything about it. And I remember thinking, oh my God, I didn't even realize. And you were like, this is one of those things that could turn into a respiratory failure if not caught early. And you explained it to me in a way that made sense, but didn't scold me. In the early days of nursing where, they eat their young, it was not like that. And it stuck with me now as I'm orienting new nurses. And I appreciated it. I still remember that story about, oh my God, I really messed something up. I could have hurt someone and I didn't think about it. And I wasn't doing anything bad to them. I just didn't pick up on something. So I used that assessment skill to this day.
I'll be honest, first of all, thank you, because that period of time was complete chaos.
Yes, it was.
But it's hard to explain to folks that have never done any sort of nursing job, healthcare job, how things like that can be missed. And I know, during the pandemic, there was plenty of kind of outside noise about, what should or shouldn't be doing in the hospital. And that's, a whole lot to say about that. But, one of the things is that, it's very easy to miss things when you are dealing with an overcapacity emergency department. And so some of the lack of judgment there is that it's something that any new nurse really could have done by mistake, is miss, a tech charting a vital and not communicating that right. So
Mm-hmm.
One of the things that you said already was about almost like a foreshadowing when you were in school with the mass. I do remember one of the things they talked about a lot in school. I graduated school in 2016. And one of the things they would talk about is, there's a nursing shortage coming. There's a nursing shortage coming. The baby boomers are going to retire from the workforce, and then they're going to become the patients, at higher rates because of the age group that they're in. And so there was all this discussion kind of about a nursing shortage even before the pandemic. And it seems like the pandemic accelerated that whole process. But there's these little things when you look back where you're like, was this foreshadowing? Tell me, like, when you think about memorable moments of the pandemic, what stands out to you as kind of most memorable early on in the pandemic?
Early on, we had, I think, one day where I came to work and there was no patients in the ER at all. It was at Unity. I'd come to the ER expecting, our standard, and there was nobody. And what I was told was that people were just scared to go. So your normal patients that you would see in the emergency department, your falls, your heart attacks, your headaches, tummy aches, sprained ankles. People were so scared because of what they'd heard on the news that they couldn't make themselves go to the hospital. And then it was like maybe 1 or 2 days after that we just started seeing patients come in more and more and more and more. And we had that small area in the back that we had sectioned off just for COVID patients, or rule out COVID because our tests took so long to process. It was back in the negative pressure area behind the triage station. I don't know if you remember.
There's 3 rooms we were going to have
for 3
COVID.
rooms. Yeah. 3 whole negative pressure rooms with the negative pressure don and doff area where you could put your PPE on. And I remember when we got our first COVID rule out in that room, I was there that day, and we were all scared to go near it. There was a sign on the door that said, do not enter, leave the door shut, see nurse prior. And like everybody was just like afraid to go anywhere near it. And then soon after that, my most memorable experience from early days was the day that we ran out of protective equipment. And I had gone to work, and it was the masks that started first. And I remember showing up. I had a patient in negative pressure, and I went to grab, we had a yellow sleeve with all of our gear tucked in it. We had our gowns, our gloves, our masks, and you would don your equipment prior to going in the room. And I went to get a mask, and there was no mask in it. So I'm already wearing my gown. I swear I haven't gone in the room yet. I just need to find a mask. So I went to the next one, and there's no mask. And I went to the next one, no mask. And I went all the way around the unit. I'm like, guys, where's all the masks? And somebody said, Katie, we don't have any. This is it. We don't have any more. So I had one in my bag that I had just taken off the night before and just tucked in. And I wore that mask for days and days and days and days because we just didn't get a shipment of new protective equipment in due to, transportation issues and manufacturing issues. Everybody was staying at home. There was nobody making anything. So even if they were made, there were just people not delivering them. Everything was shut down. So we were just stuck. And I remember hearing on the news on the way to work, somebody had recommended wearing like bandanas and, whatever you could to cover your face if you were one of our essential workers. And if we were lucky enough to get a new box of masks, we would run and grab one, and that would be our new mask for the week.
Yeah, I remember, this whole thing about the N95s, where they would give us the paper bag and they would be like, you need to last as long as possible. And one of the interesting things about that time is, the hospital tends to be very, stringent about everything's got a rule attached to it with things like that through, especially with whole infectious disease departments. It'll be like, okay, you can have this for X amount of days. At that point, it was kind of like, okay, you put that 95 after you use it in a paper bag, and you need to have it for the next day, and then you might need to have it for the next day. But like, there was no rule necessarily because nobody knew what was going to happen, right? Like nobody really knew how to eat that for, how bad the shortages would be. I also remember there were some of these things where like you heard that they were happening already elsewhere, because a lot of the things you're describing with PPE shortages, like you heard them happening in other places before they hit our area, which was state New York, but it still was different when it actually started to happen. I think there's still like a bit of reality check when we started to actually encounter those types of things, because nobody that we worked with, even those, old school doctors with 20 plus years of experience, nobody had really dealt with that before or anything like this before. Do you have other things that stick out as memorable, maybe later on, as the pandemic?
I remember they had given us shields to wear, just plastic shields to go over our faces, like a helmet shape. I don't know if you remember, it was like the big night helmet. It had a thing that went under your chin and the elastic behind your head. And I remember we had a patient in one of our trauma rooms, the bigger rooms in the front in the A zone, who had come in with CPR in progress. And one of our doctors had gone in. They were really limiting the number of people that were allowed to go in because the patient was ruled out COVID. So there were people standing outside the room, and there were those of us standing inside the room, and of course the glass door. But then we also had big HEPA filters in the room that were very loud. So we're trying to run this code with this patient on the table, and we had to intubate, and the doctor is yelling, trying to give orders to us to run the code, and we couldn't hear him because we're all behind plastic shields and we have masks on, so we can't read each other's lips. And it was so loud and everybody's trying to hand each other things. And I'm like, you want a bicarb? So it was just very intense moment. And he handed me something and told me, I need an art line in. And I'm like, I've never done art line stuff. I don't know how to set up an art line. I was still relatively new, comparatively to everybody else. And I was still trying to put an IV in and pass meds for this code. I didn't have another nurse in the room at the time. And I looked at this doctor who'd been a doctor for many years. He was always very stern-faced. And he looked at me and he's like, I need this set up. And I was like, I need another nurse. And I kind of yelled at him. And he was like, okay. And he brought Lottie in for me. And she helped me set up the art line and zero it and all that stuff on the monitor and get it ready. But she also needed to get negative pressure ready and PPE and all that stuff. And everything took so much longer. And thankfully that patient, at least during our stay in the emergency department, had a good outcome. I don't know after that, you see so many people and after they leave the unit, you don't have a chance to follow up and see what happened. But in that circumstance, it was a good outcome. And that was very memorable for me.
Do you think that, that when you talk about incidences like that are pretty memorable, there's, I'm sure, a lot of feelings involved about all of it. You're getting thrown into things very quickly. You have, yourself at risk of catching COVID. You have all of these delays that are affecting your job and patient care. Were you feeling an impact at the time, at home or in your personal life, after going home on days like that or around that time?
Yeah, I was very scared because we were all, I think, pretty scared. My daughter that was 2019. My daughter was 6. And at the time, we had no idea how COVID was going to affect children. Obviously, none of us were vaccinated yet. So I remember the day that they came into the unit, they were just rolling out the first vaccines that they were bringing into the hospital for us. And I remember that day, they only had one more left. And they came to the unit, management came to the unit and they were like, hey, we need you to come out if you want to get the shot today. So I was like, I'm in, let's go. I'm coming. And me and one other nurse got there at the same time. And we played rock, paper, scissors for it. It's like, I won. But I remember this feeling of relief, oh, it was, maybe I will protect my family, now that, but we didn't know, so it was all so scary. This is a new vaccine, are there going to be side effects? This is basically a giant trial. What is this going to do to me? And interestingly enough, I actually lactated after I got my vaccine. And like I said, my daughter was 6. I have no idea today if that is a common side effect. I guess we'll know in 20 years. But yeah, it was scary. It was scary coming home from work after, before that, we would be concerned if we'd walked into a room and been potentially exposed to something, C. diff, VRE, ESBL, some of those other contagions in the hospital that we worried about before. Those were also scary, but this is something respiratory that it's one of your vital organs that you need to be alive. And the thought of bringing that home and transmitting it to my daughter or my parents, who also shared a property with us, we were living in their backyard. So my parents were in their 60s. And that was primarily the demographic of patients that we were seeing in early days of COVID, were the older generations. And it was very scary to think about transmitting that to my loved ones, my husband. Also, I when early days yet, I had to find other childcare because my daycare stopped letting my daughter come to daycare given where I worked. They were like, no, it's too high risk. We can't have her here. Um, so that also impacted my day-to-day life. My parents watched her, and that was scary because then that's more exposure for them, because we were living on the same property, but we had two separate homes. My husband and I and Allie were living in a cabin in their back of the property, and they were living in their house. So at the beginning, before that, Allie was staying in my house with me and Jay. She would go to daycare, and then she would come home to us. She didn't go into my parents' house in the beginning. And then that was out the window. So, yeah, very scary. The whole thing was scary.
Yeah, and it's hard because, some of these were challenges that other families were dealing with, but other parts of this were kind of unique considerations. You can't completely isolate when this is your job, and you also can't stop working because
Right.
people are struggling in your family, other people are out of work. I don't know if you encountered this where, at times you were working more than anybody else in the family,
Oh, yeah.
kind of
Um,
makes it harder to say, oh, I'm going to take, maybe try to limit my exposure. You can't do that if you're the person in your family that's working the most, right? Or pulling in the most income because everyone else is having breaks at work, in and out of work. Things kept opening and shutting down, but for us that didn't happen.
yeah, my husband became a stay-at-home dad for a little bit of it because the company he was working for was not considered essential. So their business was shuttered for the early days of the pandemic, and Allie was able to stay with dad. But yeah, we were going to work for our scheduled 8-hour shift, so scheduled 12 hours, whatever you had. I was working a full 40-hour week, which was 2 8s and 2 12s at the time. And on my days where I was scheduled to work a 12, I was asked by whoever happened to be charge nurse at the time, Alicia, somebody would come up and be like, hey, can you stay another 4 hours? And he'd be like, I guess let me call my husband and see if he can manage dinner. Like, I don't know what our plans were. Obviously, we weren't really all doing anything because there was social distancing and everything was kind of shut down. So I guess so, and I remember one time I was already there for a 16-hour shift, and one of the nurse managers came up, hey, can you stay for another 4? And I was like, I don't think that's legal. And she was like, how long have you been here? And I'm like, this will be hour 15. And she's like, oh, no, never mind. I have to go ask someone else. And I think that was like my 4th day on in a row, 4 16s, I think. So yeah, it was exhausting. We were just toasted all the time, just like,
Yeah. The kind of weird shifts we were doing, because you would be scheduled, like, say for instance 7 a.m. to 7 p.m. and then they would be like, and you come in at 3 a.m. so then you're working like 3 a.m. to
yeah,
7, the weirdest long
yeah,
hours, which is the weirdest shifts. And it would always be like, it'd be like, oh, if you're coming in at 3 a.m. you could leave at 3 p.m. and you're sitting there like, no, I might as well just stay the extra 4 hours if I'm going to come in at
yeah,
3 a.m. So most people, just took the extra hours during that time.
yeah,
Um, we were talking about kind of what personal life was like, and
yeah.
family life during the pandemic for you. Do you think were there parts of this whole thing that you think were positive in some way? Like, were there things about the time that you were working during the pandemic that you feel like added some kind of good to your life in some way?
Um, from a strictly like logistical perspective, um, those extra hours were able to get me this house and in a faster way because we were working so many hours and they were offering so much incentive pay for those hours. They were like, hey, if you stay for another 4 hours, we'll make it $120 an hour for you. we'll make it another $80 an hour. And, it depended on how desperate, I guess, the hospital was for coverage for that shift. And in the earlier days when none of us had ever been exposed before, a lot of people were calling in sick for their shifts because they had gotten exposed to COVID. You would get a call from the hospital. Hey, you were exposed. You have to quarantine for this many days and you'll be out with COVID pay. And so people were like, well, crap. They had to stay home for however many days they had to get tested. And so those days where the hospital was throwing money at you, please stay. Please stay. We'll stay. We'll buy pizza. Please stay. So I was able to save up $20,000 for the closing costs on my house very, very quickly. And we moved in the summer. Oh, no, it wasn't the summer. I think it was like maybe fall time of 2020. It was definitely before winter because we moved in and it was like just starting to get a little crisp in the air. I think it was like October, maybe. I don't remember. The whole time's kind of a blur. But yeah, we were able to save up all of the money that we needed and then some, and we were able to pay off all of our credit cards. And that was just the strictly like financial aspect of it. Everybody else was struggling because they were out, their families were really hit hard because their jobs were shut down. And I remember hearing on the radio that people were not able to pay their rents. And then they were pausing evictions for a while because everything was shut down. Sorry, landlords, you're not going to get your money, but you can't evict your tenants either. And I remember thinking, I feel really guilty, but I'm doing pretty well. Like it sounds awful, but like, because I don't like to think about benefiting from someone else's misfortune, but I think in emergency department medicine, that's kind of our thing, like that's what we do. We get paid because someone got hurt, someone got sick. And I just had to kind of set that aside and remember that this is my job.
Yeah, that's interesting to hear that you had some guilt about that. I mean, the implications of making a lot of money during the pandemic are a bit complicated because, like you said, a lot of people, like your partner, was out of work. And so some people or people in the family, had other issues related to the pandemic that made the money not that much extra money.
Yeah.
It's an interesting ethical issue that you bring up where, we were making a lot of money in part because people were suffering. One of the harder things in the greater media world is, kind of hearing about how, people are making all this money off of the COVID vaccine and all this stuff. And like the pharmaceutical companies, that's a whole different story from the health. But I know on my end, it didn't always feel like, what's the right way to say this? That kind of trade-off to make that much extra money during a pandemic had a pretty steep cost attached to it.
Yeah, it did.
And, part of what makes it difficult, I think, for myself and some of the other healthcare workers I've talked to is that, you have this brief period of time where you're making all this money, but then, some of the psychological psychological effects of working during the pandemic, those can last, the rest of your life, like, months, years. Do you feel changed by the pandemic in terms of just you as a person? Do you feel like you are significantly changed in some way? And I'm not talking about, your kid got older and you changed because of that associated with and partnership and all that. I'm talking about just because of the pandemic. Are there parts of you that you think are different?
Very much. Yeah. I struggle with a lot of anxiety. And I'm taking a medicine for anxiety and depression. Just the other day, someone at work, we were talking about, how expensive things have gotten. Back to that. And it was one of the newer nurses who didn't work through the pandemic was like, I wish we could get another pandemic so that, I could get some of that money. And I looked at her and I got angry, like really fast. And I apologized to her later. I was like, I will never do that again. You don't understand what happened. And her eyes got kind of big. She's like, really? You wouldn't do it again? And I was like, are you kidding me? I was like, no, not ever. You couldn't pay me enough. There's not enough money in the world that would get me to go back into that environment. And it was the bigger city hospitals where I struggled. It was after I had left Unity. I had had some experiences. I worked in one of the larger emergency departments in Rochester, one of the big two. And I was in the emergency department, and we had, you had a team of 2 people. You had a computer and a cart with medications in it, IV fluids, IV start kits, lab sets. And you were assigned to a zone in the ER, and you would just go from one patient to the next. There was no time to document anything, because in this department, you had an area, your A pod, B pod, C pod, then all of the areas that were walkways in those pods had now been turned into treatment areas. You had beds lining those spaces, and tele units were on the walls. And then you had chairs in between the beds. You had the waiting room had been converted into a treatment area. They had turned the atrium into a treatment area. That was all filled with Jerry chairs. And there were, I don't remember how many deep, and it was just rows and rows and rows and rows of chairs from one end to the other. And patients were in every single chair. They didn't have any space. There were no dividers in between them. You just had human beings piled on top of each other, shoulder to shoulder. And each of them is there for something completely different. You had men next to women. We didn't have peds because they had a different area for pediatrics. But you just had, you'd have a 20-year-old next to Granny. She's here for chest pain. He's here for a drug overdose. And he overdoses in the chair. And we had to throw him bodily from that chair onto a stretcher. He's 5 chairs deep. So we have all of these people between us and that person who is slumped over and not breathing. So we had to physically get him out of there, put him on the stretcher, and wheel him into the front, which is, we're back in the atrium. We had to go out the hallway, down EMS hall, up towards triage, around triage, through Trauma Bay 1, through Trauma Bay 2, out toward A-Pod, into one of the larger treatment rooms so that they could start the code. And that's just one example. It was insane. We had, like I said, the waiting room was converted into treatment area, and we had our Jerry chairs. And there was this elderly man being straddled. Literally, he's in the chair like this. His nurse is over top of him like this, with a Foley kit, putting a catheter into his penis.
Yeah.
with no curtain. There's nobody. Everybody in the waiting room can see what's happening to this man in a very vulnerable area. And she's just, this is a task that needs to be done. I have nowhere to do it. I can't get him anywhere else. There's no other space. I have to do this here, or his bladder is going to rupture. He's got 900 plus cc's of fluid. Our bladder scanner couldn't pick up how much was actually in it. And it was just, I walked over and saw what was happening. And I'm like, okay, I'm just going to stand right here while you do that. And I'll hand you things as sterilely as possible, because it is a sterile procedure that you're doing in a chair with no sterile gloves. We didn't have Foley kits, so she made her own Foley kit, with a bag and the Foley. I would never, ever, ever choose voluntarily for any amount of money to go back to a situation like that.
Yeah, I was lucky that near the end of the pandemic, I learned about this whole moral injury concept. I don't know if you've heard about this, but this is a good example. And it's essentially that, you're put in a situation where you kind of have to do things that are against your morals, but they're not against your morals, right? You're making the best choice that you can in that situation. And this is a really good example because in a normal situation, you would think that, oh, it's wrong to violate a patient's privacy, and it's wrong for other people to have to see this, but you're weighing one wrong against another. And in this case, the other wrong that you have that you're weighing this against is the possibility that his bladder will literally explode. And this is a man who wasn't going to have access to a private area likely anytime soon. And so you end up with a situation for the nurses where you are doing something you know is wrong, but it's also the better choice given the situation. And there's this whole theory about moral injury where that causes anxiety, PTSD, causes depression, all of those things in the person having to make that choice, because you would then have to live with the decision that you made in that situation, right? You have to live with whatever choices you made in the chaos. And sometimes those choices caused violation of privacy, caused other types of harms while still being the better option. And that's kind of the difficult part of being in overcapacity conditions in an emergency department is you can't do everything by the book anymore. It's not humanly possible. I say we went in, and just a brief story from me, but myself and Jeff came in one day and we were in B pod, and there was a full pod of boarders with still people coming in to the halls for workups, and there were only two of us, no techs, no other nurses. There were only two of us, and every patient, there's this full med list of things, or full list of meds due on the MAR. And that morning, this was a 7 a.m. shift. There were
So you're doing your morning med pass.
Morning med pass, people that needed labs drawn in, IVs put in, that were coming in, people that were there for respiratory issues where we needed to monitor their oxygen levels. All of those things were happening. And that's a good example again of situation with potential for moral injury, because somebody is not going to get toileted right away. Somebody is going to pee and have to sit there for a while, because the person that needs the oxygen, the person that has a very important medication, steroids, antibiotics due, those people have to come first. But you're still left in a situation where wrong is happening, where that person is sitting in their pee, where family are upset that their loved ones have been neglected, because they are being neglected, but they're being neglected because of the situation not being manageable for the number of healthcare workers that there are. So I just, your story made me think a lot about that. Are there certain parts of it besides just the experiences that you feel like contributed to your anxiety over time? Were there parts of working in the pandemic in particular that were hard for you to manage, on an emotional level?
Yeah, I struggled with the fact that my other coworkers were also struggling. And so, they were not able to manage either. And so you're not only trying to juggle the aspects of your own assignment, but if your coworker had a patient who was much, much sicker than yours, you're running over to help them with that. And your own patients are suffering because their patient needs a central line and pressors. Your patients need Zosyn. So what comes first? You've got to hang blood on this person. This person's covered in their own feces. I'm sorry. We can clean up the feces, it's awful. But when I had been traveling, I had a situation where it was towards the end of my travel time, and I had been kind of just burning out for a while. And this particular day, I was at a different hospital at the time. I had my own full assignment. We were in C zone, so there was curtained area, and it wasn't at Unity. It was at a different hospital. You had your med room, and there was a bed right next to the med room door. And I had a patient in that bed. And the whole unit was on fire. You're running from just putting out little fires throughout the unit, trying to get things done. Like you said, you're drawing labs, you're passing meds, you're drawing labs, you're passing meds, you're sticking IVs in, you're putting a Foley in here. This granny is trying to reach out and grab people. She's got to go in restraints, and of course there's no visitors there. So you can't have someone sit with her. There's no staff for a one-to-one. You're just kind of, every time you walk by, you're pushing her back in bed, My other patient, when I come in the morning, was already pretty obtunded. And I was told was because he had received pain meds and blood pressure medicine, and had gotten diuresed. So he was pretty out of it. But had come in for back pain, and his vitals were improving. He was a little hypotensive in the morning, but not bad. And I was just checking on him throughout the day. I had him on telemetry so I could see his heart rate, and I was walking by him constantly all day long because he's right next to the nurse's station and the med room door. But I'm busy. I'm putting out fires. Like I said, I'm just one after another putting out fires all day long. And doctors were coming up to you, and even patients that were not your patient. They're like, I need these labs drawn. Can you stop what you're doing and go draw these labs on this patient for me, please? They're having chest pain. I'm worried about an NSTEMI, please. Okay, so you drop what you're doing and you go do that. So my patient that had been sitting in that bed, I went over to get vitals for his 5 p.m. Lasix, and he was deceased, sitting in the bed. And he was in PEA, so the telemetry was still showing a normal sinus rhythm, but he didn't have blood pressure. And I looked at him and I was like, he's not moving. He's not breathing. Oh God, he's a DNR DNI. I can't fix this. And I just got this horrible sinking feeling of, oh my God, I killed him with my neglect. And it was not anything that even to this day, I struggle with it because I know intellectually that I didn't kill him. I didn't pass a single med on him at all that day because he was so obtunded in the morning. I didn't give him any PO medicine. I was worried that he was going to choke. He was waking up, but he was still wouldn't pass the swallow eval. So I didn't give him a single medication. I didn't do anything to deliberately cause this man to fail. He just did. And he was still warm. So my instinct was to try to fix it and to put my hands on him and pump. I didn't because he's a DNR DNI. And I really struggled with that. And I still struggle because I worried what if I had only had him in a perfect world and maybe 2 or 3 other patients, would I have caught it sooner? Would he have shown some sign to me that would have made me, would his respiratory rate have been different like the other patient? Would I have seen something as a nurse with judgment that would have made me cue into this? But because I didn't have that time, I'll have no idea for the rest of my life if I truly missed something or if he just dissected a AAA and died really quick. And I have no idea because there was no autopsy. There's no closure. So I still struggle with that today, going into situations where staffing is a concern. I worry and I do get very anxious about, okay, we have this many patients with a ventilator today. I need another set of hands in here. I need an LPN with me. I need patient care techs in here. And I'm being told from management, I'm sorry, we don't have the extra staff. You have to cover this unit with you and one other RN. And I get angry and I will yell at people. And I find myself having to come back later and apologize to people, especially in supervision. And I know that about myself because that comes from a place of trauma. Like I experienced something that has changed me in ways more than just nursing, but I don't ever want to feel that way again. So helpless to fix something, so helpless to help my patient. That's my job, is to keep this person alive. And I can't do that if I'm not there, so Yeah, I'm forever changed.
I'm very sorry. And I want to say I'm sorry for your loss, which is not something that we say to healthcare workers enough, right? It's always like, we don't talk about losing a patient as a loss to the healthcare providers. We talk about it as a loss to that person's family, their friends, their, spouse, if they have one. But a lot of time it's a loss for us. And that's not something that we talk about a ton. And I think, one of the things that your story shows, I think, is that another thing you encounter in an environment where you're in these kind of pandemic crisis conditions, short staffing, is that when you put in a situation where you have to make choices about triaging, choices about which things you're going to do and which things you're going to neglect because you're only one person and you can only do so many things, that the choices that you make may be right at that time and wrong in hindsight. And in the case of this patient, you don't have the closure of even having enough information here. But people think I think there's a misconception that, when you're put in a situation as kind of crazy as this, that you can make 100% of the time the right decisions based on the information presented to you. Sometimes with the information presented to you at the time, you make choices about triage, about who you're going to see first, second, third, who you're going to, give meds to, whose labs you're going to do. You have that patient, oh my God, they could be having a heart attack. You have that patient where they keep taking off their oxygen and oxygen's dropping. You have all these things happening, and you may not know that one of these choices was wrong until after someone gets hurt, after somebody dies. And that is part of the unfairness of working in these conditions, is that there is no way to know 100% of the time who to see, who to pay attention to, who to do labs on, who to give meds to, and who you're going to have to neglect. There's no way to know that that's the right choice until after the fact, with the information that you start with during that shift,
Right.
and that you gather during that shift. And so, yeah, I mean, that's a big weight to have to carry. And I mean, they really make sense that your responses are what they are with some of the newer staff. What do you think you want to communicate to the newer healthcare staff, but also people that really didn't know what was happening during the pandemic, or people that are too young to even remember? What do you want to communicate to them? It's very hard in the moment when things are happening because you get triggered, and I've been through
Yeah.
this where, so there's a trigger that reminds you of kind of the conditions that you were in, and it's easy to get really, really angry, really stressed. But then in those kind of like lower stress times, sometimes I think about what's important for people to know about the pandemic. That's kind of what led to this, right?
Yeah.
What are the things that you want people to know?
That it was real.
Yeah.
That it actually happened and that we experienced it. And that I don't know, that the way that we perceive the world now is different. And the way that we live our lives is different. And it's not just something that happened for a little period of time. I'll never be the same person that I was before. And I loved the person that I was before. I was jovial. I was a happy person. I was a bubbly person, which is why everyone told me I should go be a nurse in the first place. And they were like, you're going to bring so much joy to people in their darkest moments. You're going to be that beacon of light, that happy person who's going to come in and just smile and lift somebody's spirits. And I haven't felt like that in 5 years. So yeah, I hope that people in the future, looking back, don't just look at the numbers and, this many people died. This is Oh, and there's always going to be this rub of people who don't actually think that it was that bad. But it was. And I had people in my own family who were telling me, "Oh, you're just making it up. That's not real. That's something that they're just saying on the news. And, it can't be that bad. You're just being dramatic." And I don't know how to I've stopped communicating with them because for my own coping with it, it's hard to be told over and over again that I'm making something up. And so to just tell people that, yes, it was that bad and we handled it the best that we could. And if their family member was there during that time, I'm sorry it took me so long to get to them.
It's hard to hear the level of pain here. And sometimes I hear about all of the problems and inconveniences and struggles that especially young people had from the shutdowns,
Yeah.
from quarantines. I hear a lot about how, kids now may be struggling more with social skills and how it was difficult for some people to deal with the loss of socialization from a mental health perspective. And because I was there like
Yeah.
I about what was the alternative.
Right.
And I do worry that there's a lot of people that just know the problems of shutdowns, the problems with quarantine, but they don't know the other side of that and what would have happened otherwise, and how bad it already was and how much worse it could have been with more and
Yeah.
more COVID patients. Um, I'm sad to hear that you had to distance yourself from some family relationships, but that's also a very common experience I've heard with healthcare workers because, it's kind of like, if you're a Vietnam vet and you come back from the war and, people want to protest the war, maybe not directly to you, maybe not to your face, maybe not
Right.
experienced all of the things you did. Not that the protest wasn't warranted, but there is a fine line between having your beliefs about whatever your thoughts are about healthcare systems and pharmaceutical companies, and telling healthcare workers to their faces that that what they experienced firsthand is not real. Um, I think that this really segues into one of my last questions, which is, with everything you've been through, with how much it's changed you, and how you had to become a different nurse than you thought you were going to be to help these people, because you were sometimes the only person there for them, right? With no families in the hospital, you were that person there with them.
Yeah.
Why did you decide to stay in nursing? Because that was a choice, right? Some people
Yeah.
left, or they
Yeah.
left patient facing roles, or they left the profession.
Right. I Every once in a while it still tickles me like, do I really want to keep doing this? um and in the moment, during the pandemic, it was out of necessity. Because everything else, the alternatives were gone. There was no opportunity for me to be able to support my family without being a nurse. I couldn't quit. So that also led to a lot of anxiety because I remember waking up in the morning and thinking, oh my God, I have to go to this place. I have to go. I don't have a choice. I can't call in. I have to go and I don't want to. And I remember a couple times waking up in the middle of the night just sobbing and my husband rubbing my back and being like, babe, it's okay. It's okay. And I'm like, it's not okay. It's not okay. It's bad. I don't want to go back. Please don't make me go back. And he's like, babe, we can't do anything else. Now, post, the fallout, it has made me such a stronger nurse. because of the things that I did during that time, the things that I learned. And doing these things hands-on in the ER sent me to where I am now in the intensive care unit, doing those rapid sequence intubations. And, you're getting that rock ready, you're getting the etomidate and the sucks, and down they go. Tubes in, 7.5, 25 at the lip, get them to the ICU. And then I'd had no idea what happened to him after that, and my plans right now are either to become critical care NP or CRNA, because of those skills that I got and the ones that I'm still developing in intensive care. I find that day in and day out, seeing those people come off the vent later on has been very therapeutic for me. They're not COVID patients anymore. But I'm seeing people with, COPD, just terrible pneumonias, diabetic comas. And, this person's really struggling. Respiratory rates in the 30s. All right. Bicarb's pretty low. pH is 7.14. Let's go. Intubate. A couple days later, we do our spontaneous awakening trials. We see how we do. It's a new set of skills that I've learned, and it's exciting. And we extubated a lady just the other day. She's one of our frequent flyers, but every once in a while she comes in and she's just in such a good mood. And we intubated her in the ER, and she was intubated for a couple of days. And she wakes up on my shift, which is always so wonderful for me. So I go in, I've got my stuff set up. We take that tube out. She's wide awake. I'm like, "Can you say hi, honey?" "Hi." It's thrilling. So I wouldn't want to do anything else.
What's really touching for me and hearing about your journey through this, and how you thought you were going to be this certain type of nurse, right? The friendly, caring, bubbly nurse. What is really touching to me is kind of hearing this journey of how you've lost that person, right? You are not that person anymore, and you have this kind of grief about not being this cheery, bubbly, "Oh, I'm going to help your mom, get her better." You're not that person. But like a lot of people that have been put in situations like this where they've had to have a lot of courage, you become this whole other person that you didn't even know was there. You've evolved into this person that has these critical care skills, right? And when you were talking about um the code where you couldn't hear anything, you didn't know how to do
Yeah.
it, you were brand new, like these are the kind of experiences that showed you that you can be this critical care person that maybe you never thought of yourself as. And so it's really interesting to hear your journey, but also that there's still parts of the job that are kind of profoundly rewarding, right? Because I will always, always, always be a supporter of, the healthcare workers in terms of like their emotional, mental health. Because if you leave, the place that you are at, the ICU that you work in, will lose just a wealth of experience that you cannot teach someone in school, right? And this is also what we were trying to tell, I think, these hospitals, with the way that they were treating healthcare workers that were leaving en masse during the pandemic, right? People retiring early, people, quitting to go travel, quitting to do outpatient jobs, that the experiences that you get working as a nurse, and especially these accelerated experiences, like you got
Yeah.
10 nursing experience in 6 months during the
Yeah.
pandemic, like that they can't, no new nurse can just walk in that place and replace You can tell them everything you know, but it's not the same. And I bet you can place an art line like fast as hell at this point. Like I bet you can do it real quick.
I've got my tubing ready. That pressure bag's up. Let's go.
Yeah, so I just, I know healthcare workers don't like, usually a lot of us don't like the mushy stuff. We don't like to talk about like courage and things, but there was a lot of pieces of courage, and especially in not being a graceful swan, getting through it, being awkward, having these terrible patient deaths, patient codes, but also crying at night and going in the next day. Like that takes courage to walk into a job that has been really done for you because you have to, right?
Yeah.
Um, I want to make sure I don't have any more like last final questions for you. Do you have anything else that you want to say?
I feel like there's so much that happened. It's hard to finalize any of it. Like there's so many different aspects of just, how this is going to impact for decades to come, healthcare in general, and for the good or the bad. It taught us a lot. Whether we are open to those lessons, that's something different. I don't know. I hope that eventually we can get to a better place in healthcare in general, and just being human beings in general, how we treat other people, whether we're in a pandemic or not. You know, how, I don't know. There's so much. There's just so much. I don't know. It's hard to just pinpoint down any particular thought about it. I don't know.
Yeah, I know what you mean. There's just so much here that condensing it into, even an hour or an hour and a half talking, like it's just not enough time to capture even the highlights, right? Even the highlights
Yeah.
of happened for us during the pandemic. Um, moving into the future, you're letting everybody know that it's just hard to express everything that even happened, and that there's probably lessons to be learned here that we may or may not heed, right? Are there other things that you would want people 20, 30 years from now to know in terms of really important take homes?
Just to be good to each other and patient and kind. You never know what someone's dealing with. You never know, like if someone just left a 16-hour shift at a hospital, and if they just, were jumping on somebody's chest trying to bring them back to life, and now they're at Walmart. I've had those nights myself, even recently. And, pandemic or not, whatever we're dealing with, whether it's the country, the world, seasons change. Everything's from one day to the next is different. And you have to just choose to be kind to others and just get through whatever you're dealing with. Keep going. Keep trucking along. You just gotta get up in the morning and go.
Do you feel more helpful to other people now after everything you've experienced?
I
Do you feel
find myself, I'm still very tired after everything that happened. I'm still very emotionally tired, physically tired, after a long day at work, I just need to take a bath, and I find that some days I'm more open to going out and being friendly and, going shopping with friends, or, hey, you want to go get some dinner? Sure. But most days I can't even get up the energy to leave my house. On my days off, I don't want to go anywhere. I don't want to see any people. If I see a car accident on the side of the road, I'm going to get out and I'm going to help, because that's what I do. but to make a choice, an active choice to go participate in humanity as a whole from one day to the next has been long since gone. I don't have any desire to spend any time with anybody anymore. And I don't know if that's necessarily from the pandemic or systemically, like just being around as a general rule, being a nurse in a hospital setting, you're constantly around noise and people, and machines are beeping and someone's screaming in this room, and oh, someone just threw their pee at me and now I'm sticky and I just don't want to be anywhere near there's anyone that's not my husband and my daughter. So a lot of days I just don't go anywhere. I just want to stay home and just nest here, and that's okay. It's probably not the most healthy thing ever, but I guess there's worse things I could do to cope.
True. That's absolutely true. Yeah, I've heard the gamut with how people cope. Some people need more or less alone time, but also I've heard everything from people who developed pots to people who started drinking more to, people who are needing, more different, medications or therapies. And so you're right. I mean, a little bit more alone time, depending on the person, may not be the worst thing in the world. Just really depends.
This was great. I don't usually talk much about the things that happened during COVID. I hope that to see more of this in the future and how people can learn from it and take from it, so that they can lead with kindness. This has been grounding and educational for me in a way, because just telling those stories out loud when really I'd been kind of avoiding them in my own mind, has been kind of helpful for me to understand the ways that I do things now. That I just kind of knee-jerk reactions to things I didn't really put two and two together. Oh, yeah, that's probably exactly why that happens now and why I do react in that kind of guttural way. And so I think this has been very helpful. I would like to see more of these with different people. I'd love to hear other people's stories from, I didn't think I would. I kind of thought I would want to avoid it the way I'd avoided my own. But I think I would like to hear from other people so that in my own way, I can validate what I saw and experienced, because it kind of does feel sometimes like you're alone on a little island. And it would be nice to hear that other people had those same experiences. And I know that they did, because they were there with me, right alongside, experiencing it the same way. So maybe to connect a little bit with those bits of humanity that see the world the way that I do would be nice.
Yeah, absolutely. I was going to tell you, and I'll probably cut this out, but if you know more people that you work with or have worked with that you stay connected with that might be interested in doing this kind of interview, really anybody that worked in a healthcare capacity over the pandemic, I'm interested in talking to. And, a lot of people, I want to talk to if they're in the hospital, but I'm also interested if people were doing EMS or if they were doing community-based work as well. Like the other interview I did that we're trying to get finished up that the videographer did was somebody that worked both in the hospital, in the Rochester Regional Urgent Care, but also did some like community based trying to get people vaccinated when the vaccine came out. And so if you know people, let them know what I'm doing, and I'd be really open to talking to anybody as long as they actually were working during the pandemic. Yeah. And I'm, actively seeking out some new people. It's like, I'll see people on internet forums, like on Reddit forums or on the comments of videos on YouTube or TikTok, or where people are taking that little window that they have to like talk about how bad the experiences were, but kind of like pulling all those people in from all over the internet is kind of difficult. Part of the reason I wanted to trial the video with you, besides the fact that I've had challenges coordinating with the videographer, is that I do want to interview people all over the country. I don't know about international yet. Maybe if they are Canadian, I would do it now. But as far as, starting out, I do think too, from the outside, everybody, some people look like they're losing it, but a lot of people look like they're handling things more like a graceful swan. And it's pretty normal experience for, I think, almost anybody I've talked to have a bit of a, couple crying sessions, or, real struggles with dealing with people, or, a lot of that hyper reactivity of having to be on high alert at work so much, especially during the pandemic, being really reactive. Like it's a really common experience, but a lot of those things are things like you don't see on the outside in other people. You really have to talk to people to know how much we all weren't graceful swans at all, right? We were all just like figure it out, and we were all like, it's like teenagers, how teenagers are like so awkward and they're always trying to like figure stuff out in the most awkward, like fumbling kind of way. Like that's kind of what, the people that I know that I worked with, that I talked to on a somewhat regular basis, like everybody just kind of fumbled through it as awkwardly as we possibly could. Just no guidebook here, right, for dealing with this mentally and emotionally. And honestly, and again, I'll probably cut this end part out, but it's like one of the big ways the hospitals fumbled was just the total inadequacy of support for health workers, total inadequacy of support. They could have offered so much more to the workers, and they had their priorities. One of the things that drives me crazy is that, during the pandemic, the technicians, like including like the ED techs that were like one person maybe at the triage desk, were making, I don't know, maybe $15 an hour. And the head of Rochester Regional made millions that year, like millions. And that drives me crazy. It drives me absolutely crazy. And then later we got emails to us as providers when I was in the APP, I'm still in the APP service, about how our pay is so competitive. Oh, you know what this was? This was around the time RGH was unionizing. Their emails, our pay here is competitive. I mean, maybe compared to Strong, but that's not the issue. The issue is is running the whole ED at $15 an hour, paid more than, in the double millions that year, right? So it's just really hard. The amount of things that just went terribly wrong all in a very short period of time.
It is a struggle when these people come in off the street and they have no experience. They're not licensed, and they come in to do these patient care tech roles, and they're making less than they would make at Subway. And you're like, why am I here wiping somebody's butt when I could just go down there and make a sandwich? And this person is screaming at me and trying to bite me. Why am I dealing with this? I could just go work at the movies. It was insane that the choices that were made when we were so, and still are, so short-staffed. And now I think it's kind of going towards the worst way, because they saw what we could do when pushed.
Yep.
And they're like, oh, you did it then. We were able to work with 2 nurses for 15 patients, 16, 20 patients. You had 2 nurses and no tech. Look at how many now you have 3 nurses.
Yeah.
And now, like, look, you have a patient care tech who can help you with vitals. They can't do your blood sugars. Nope, they can't do your blood sugars, but they can do your vitals. Maybe we'll let them bladder scan. Maybe we'll let them do a bladder scan if they get competency, but they're not going to get any more money for it. So they probably won't.
Yeah, this kind of squeeze is happening everywhere. And we saw in the APP service that, when we had this, we lost a whole bunch of staff because how the staff were treated, and also just the general conditions of the pandemic. When we got all the staffing back again, it was like, oh, it was like celebrating the bare minimum,
Yeah.
the
Like,
bare.
this is what it was before the pandemic when we were already short-staffed. Like,
Yeah, I definitely think, another thing about doing this video series is I think that there's going to have to be some different kind of incentive here for people getting into healthcare careers. And by that, I mean, people are walking into such a challenging environment now, is new staff, right? They're going to be off orientation and in a couple weeks on a med surg floor and be charged on that floor in 4 months. And, it's just going to be, difficult. That's a bit of an exaggeration, but not too much of an exaggeration. I think that the healthcare workers are going to have to know that it's okay for the younger healthcare workers, it's okay to advocate for themselves. Because what I noticed in these younger folks that didn't work during the pandemic, they're a little more afraid of like talking back to management or pushing back on decisions administration's making or decisions that are being made on the unit. And I think that the pandemic pushed a lot of us to like this psychological point where we just didn't care about getting fired anymore or what that anymore.
yeah.
Do what was right for ourselves, for our coworkers, for our patients. And I think that we could inspire a new generation of like nurses, NPs, maybe some PAs and doctors as well, but in a more realistic way where we let them know that they're going to face kind of these enormous challenges in healthcare, but that they are, in the position of power here and not the hospital system. And that, when it all starts to fall apart, they can't, at the end of the day, these hospital systems cannot do it without us. And so, it's hard because, we don't want anybody else to experience the kind of trauma we did during the pandemic, but also, you know, hearing, how much we can really advocate for ourselves or really be courageous or really challenge the hospital systems in some ways is probably going to inspire more people to get in healthcare careers than, just the old school, kind of what's the word? Kind of what you were presented with as a nurse. Oh, you're going to help people and,
Mhm.
you're going to help that grandma. And it's like, there are a lot of people that may want to get into healthcare based on your story that wouldn't want to get into healthcare if they just thought they're going to be taken care of, like, somebody in a nursing home all the time. Not that we weren't
Right.
doing,
Yeah,
but
we did that too.
so I don't know if this makes sense, but I guess what I'm saying is that there's some people that if they knew the real story of like healthcare and what it's like, actually would be more interested in getting into these jobs. I still think that there is a perception sometimes of nursing as like this softer, weaker profession, not by people that know nurses or have been patients. They don't see it that way, but
Mm-mm.
just it still is this kind of like soft profession, I think, at times, in this helping profession, when in fact it's a very tough profession. And I think that there are people that would be attracted to that as a career path if they knew, that they would get an opportunity to be tough in this job,
It's
that
funny
it's
that you say that because, like, when I was working at Rochester General, I was in their ER, and my aunt, it's not funny, but like, so like dark. So she was my favorite Aunt Vicky, and she had tried to commit suicide. It was during the height of the pandemic, and she was isolated away. And she was just like hit hard. She wasn't taking her antidepressants because a lot of people weren't. And so she wasn't spending any time with anybody because a lot of people weren't, and especially when, people heard that she was spending time with me and where I worked. So she tried to commit suicide. She took a bunch of pills and tried, so I had heard about it from my mom. She was living in the cabin that we moved out of when we bought our house. So I had gotten a strange text message from her, from my aunt. And I called my mom and I was like, I'm worried about Vicky. Can you please go check on her? I know she's in the back. She's like, oh, she's probably asleep. I'm like, no, she texted me, but she seems weird. Please go check on her. And she was out there and she was crying and pretty belligerent and just hysterical. And my mom's like, no, there's something wrong. You need to come out here. I had just finished up a 13-hour shift at Rochester General. And I lived in Lyndonville. I don't know if you know where Lyndonville is.
No.
You know where Brockport is?
Yes.
So Brockport, so you got Rochester, Brockport, Albion, Medina, Lyndonville.
Oh, I know where else too.
It was about a 15-minute drive. Okay. So I got about 45 minutes into my drive when I got that text, and I called my mom, and so I went another 35 minutes out of my way. It's now about 10 o'clock at night, and I go out to the house, and she's like freaking out at me. She's like, just let me die, just let me die. And I checked her blood pressure, and it was pretty low, and like, yeah, Vicky, we're going to the hospital. And she's like, no, I'm not going. I'm like, Vicky, I'm not asking. And for generations, Vicky has been like the fireball of the family. You know what I mean? Like, she's the big boss. Like, nobody crosses Vicky. She's scary. You know what I mean? Since she was a kid, since she was a teenager, she was the Spitfire. Nobody crosses Vicky. And so she's sitting there and she is telling me, she's got her pride on, and she's like, I'm not going anywhere. I'm going to lay here and I'm going to die. And I was like, over my dead body, I'm going to pull you out of here by your hair if I have to, but you are getting in an ambulance and you're going to the hospital. Mm-hmm. And of course I won. I called the police because I was like, I'm tired and I've had enough of your crap, and you are going to the goddamn hospital if it kills me. I'll call Jay out here. I'll have him throw you over his shoulder and he'll fireman carry you across the yard. So she left kicking and screaming, and she got in the back of that ambulance. She was yelling and cussing me out the whole time. And I looked at my mom and I was like, that is the second time in my life that I have pulled someone out of that house who's tried to commit suicide. And she looked at me and she just hugged me. And she was like, I am so sorry that this happened to you tonight. Like, this shouldn't have happened to you. But you're the strongest person in our family now. You're the tough one. And I was always the bubbly, sweet one that was so like kind of cute and airheaded, almost in a way, like, oh, everything's lovely, everything's wonderful, and butterflies and rainbows. And now I was this like dark, stalwart, like, I am a Viking and you're getting in that ambulance. And it did. The whole thing, I was exhausted. It was a COVID day, like at Rochester General in the height of the pandemic. And she chose this day to cross me. And I'd had enough. I was like, nope, not today. And she's alive today because of that. And people know now, in my family, that I'm not the one to be crossed. Don't cross Katie.
What a just little gem to have in just the worst circumstances, though. Just the worst circumstances to have just this little piece of, okay, we got another generation of leaders now. It's you.
I'm the one. You don't cross Katie.
It's incredible. Yeah, honestly. All right. Bye.
Bye. Thank you.